this man right here, our MC for the event, Jonathan Small, the Executive Vice President of the Oklahoma Council of Public Affairs, has been at the center of it. And he's been very gracious to us all for pushing the T-shirts and pushing the movement and actually helping us trend on Twitter there for a few minutes. But what he's really been is a powerful force in the movement, and his organization has been a powerful force in the movement, and they are taking heat for it. And they are largely outsiders from a lot of the donor class here because they're standing up for the principles of the free market. And so I thought it was important to both thank him for what he's done, but also to learn what has happened here and how we might be able to repeat it. And so I don't want to take too much time with me, but Jonathan, if you could talk a little bit about what happened here in Oklahoma and what you did, and then we'll kind of play it as a conversation for a little while.
Great. So one of the things that I should mention so that you're aware of what the Oklahoma Council of Public Affairs is, because I want to connect something for everyone. So we are a free market public policy think tank, and so you're already falling asleep. But what we do is we have this goal or this vision for Oklahoma that it would be the best place to live and that individuals would be empowered to gain the things that they and their families need and be able to pursue happiness. And so we just kind of have some key principles that we believe strongly, first and foremost, in as limited government as possible. That's the first approach we take. Then the next thing that's really important to us is the pursuit of free markets and individual responsibility. And so the reason that's important is because we're not alone. I would almost guarantee in every single one of your states is a state-based think tank that thinks just like we do. And so I'll give you a little bit of information later on how to connect with them, but there's been some incredible synergies that have happened with us. And so you talked about what happened from a legislative standpoint. Well, so first of all, I have to give credit to where the credit is really due, and that is the doctors that are here in this room that were tired of crony capitalists beating them and their patients into the ground. There's a unique thing about Oklahoma. Most people don't realize this. So yes, there's a lot of healthcare cost challenges in Oklahoma. But when you look at healthcare spending in Oklahoma historically, it has always been well below that of most other places in the nation. And why is that? It's actually because we have the highest amount, depends on the year, of per capita specialty hospitals and independent physician-owned facilities. So from our organization's standpoint, when we began to look at the healthcare issue a decade ago, it made complete sense to us that the more supply that you have of doctors who own their own facilities, who are providing options for their patients, the better for the market and consumers in Oklahoma because of competition. So a lot of doctors were already tired of, their lives being run by the very large corporate interests and crony capitalists at the large hospital systems that were trying to basically penalize and squeeze doctors. So we began to become aware of the work of Dr. Keith Smith and his partner, Dr. Lantier, at around 2009, even before I had gotten to OCPA. And I had mentioned that kind of the first thing that started for us, as you know, healthcare costs are soaring. They are particularly soaring, as you heard from Adam earlier, in the government space. In Oklahoma, for example, our Medicaid budget has grown over the last decade. What Oklahoma state taxpayers have to pay has grown 161%. The incentives are definitely aligned wrong in Medicaid because there are no co-pays. There's no incentive at all. One of the things that we found is contrary to what the hospitals will tell you, Medicaid actually encourages emergency room spending because that's where they get the most payment. We looked and we noticed that in Oklahoma, Oklahoma taxpayers were spending over $178 million a year on emergency room reimbursements just for Medicaid patients. That's just emergency room visits. The total program is nearly $5.2 billion now. So as we began to look at these kinds of issues and the fact that the state employees' health insurance plan had expanded in costs almost twofold over the last 20 years, we knew that we had to do something about healthcare, because our job is, again, we're looking out for consumers. We want state and government employees to get the best care that they can, but we also want taxpayers to be able to keep as much of the fruits of their labor as possible. So we began to highlight the work that was going on by Keith Smith and the Surgery Center. And at that time, there wasn't anything going on in the government space. All we knew and were aware of the private companies. We later met with Jay Kempton and his group, and we knew what was going on at the Surgery Center and with the Kempton Group, Premier Providers. So we got this crazy idea, I guess I should say I did, that it was time to bring this to the government space. And we held a very large conference on how out of control healthcare costs had become, and where we just dared Keith Smith to take the podium for 25 minutes and open the eyes of lawmakers about the grand scheme that was, really honestly destroying taxpayers and families in Oklahoma with cost. I think I mentioned yesterday, shortly after that meeting, my boss was visited by an executive from one of the very large hospital systems who had heard about this meeting and was concerned about some of the information that our organization had begun to put out about how out of control hospital costs had grown, or healthcare costs had grown. And suggested, and some others in the community suggested, that we didn't know what we were talking about, that we weren't an entity that was worth supporting, and that we should use our influence and our reputation for something that was more productive than to badger the great community enterprise and development that were the hospital systems in Oklahoma. So there's a unique thing about state-based think tanks. We are like you. We start with principle. We don't start with an outcome with which we hope that our friends get enriched. So it was funny because that kind of meeting was actually the exact wrong kind of meeting to have with people like us. When this person left, at our staff meeting, we were high-fiving, planning on how to dig even deeper and to really take the game now to those that were constricting the options of consumers in Oklahoma and hurting people. We see, I really appreciate what Jay said yesterday. So we highly appreciate, I hated school. I could not do what you guys do because I couldn't have stayed in school that long. I would have died. But not only do we see you as doctors, we see you as sellers, and you're small business owners. And that's real important to us. And so we see when you allow a few groups to control and dictate and badger and blackmail small business owners as a problem, doctors. So we began to work on, at the same time, we didn't know it was going on at the same time, we began to work on trying to bring the options that were being provided by the Kempton Group to all these community banks in Oklahoma and a number of the businesses like Bank First that were now using this to the state. And unbeknownst to us, thanks to the guts of Oklahoma County, they said they'd had enough. They were tired of what they were seeing. And so we began to talk about the story and highlight the story of the fact that in Oklahoma County, in just their first 2 or 3 months, they had saved close to $400,000 in healthcare costs by beginning to incentivize Oklahoma County patients. So I'm going to testify to what Adam said earlier. I've been studying government finance. The government healthcare programs are the worst on incentives. They have the lowest copays and the lowest deductibles. They do everything they can to mask cost. That way then lobbyists can secure all sorts of caveats. And I'll tell you about the one that we were able to eliminate. So we began to highlight that problem, and highlight that problem and then the success of Oklahoma County. And then in 2014, we got the idea that it was time for the state's health insurance program to be able to do the same thing that Oklahoma County was doing. As you can imagine, the hospitals and their lobbyists descended upon that piece of legislation and killed it near the end of the legislative session. So think about this. In a year where the legislature has a $300 million shortfall, and your businesses and your contacts and all across industry, you're hearing the movement of moving to self-insured plans, and here on the table is an option for lawmakers to save their employees and taxpayers millions and millions of dollars. And it was snuffed and choked to death in the crib by hospitals. We didn't take that lightly. And you'll hear I have a very sharp tone about this topic because I have a personal story, which we'll get to in the second half. And so we did something that was very unique for OCPA. We decided that we couldn't do this ourselves and that we wanted to make this hurt. So I said we did something that we've never done. We approached several of the government union organizations, and we told them our story, which is what we believed. It was just very unique to find ourselves across the table from people that generally hate us and are fighting against some of the very things that we're trying to achieve. And we felt that it was unfair that for state employees, that instead of getting salary increases where they could funnel or use their money as they saw fit, that the vast majority of increases in compensation in Oklahoma was going to a bloated health insurance program to pad the pockets of people that had made carve-outs for them in state law. And much to our surprise, they actually agreed with us and actually began to support our effort to give state employees the same option that Oklahoma County employees had. So to the end of that story, by the time we got to mid-session in 2015, there had not been one vote on final passage against that idea. And here's what had happened. So here's what was going on. As you can imagine, lobbyists 2 decades ago for these large hospital systems had figured out that the best way to help pad coffers and increase healthcare revenues for them would be to prevent the state's insurance plan from incentivizing employees based on cost. So there was a very arcane provision in state law in Oklahoma that essentially said, regardless of the procedure, regardless of the cost, your copays and deductibles have to be equal. So as we've heard the speakers this morning, so what was happening in the state employees plan is whether you chose to go to an ambulatory center or the hospital system that was charging 10 times what that ambulatory center might be, the copay and deductible was the same to you. So as you can imagine, as a state employee, there was no incentive for you to go to a lower cost facility because the state's employee plan was still going to hit you just as hard as they did if you went and chose an amount that was 10 times that. So just with one sentence, we recommended changing that statute, and our 501c4 lobbying organization pushed a bill, House Bill 1567, which said that the state was now allowed to incentivize employees and adjust copays and deductibles based on cost and performance. We had several people behind the scenes approach us and ask us why we were running this and would we stop it. And we have a unique thing, we call it a scorecard. We feel that it's important for the public to know, and a number of the state-based think tanks have this as well. Politicians love to talk about what they're going to do for people and how they're going to help both sides of the fence and competing interests. So we want to smoke that out, if you will, and we produce a scorecard, and we inform the group that, well, this bill that was going to help teachers and state employees was now a part of OCPA's scorecard. And it would be the test, if you will, of how we evaluated whether or not lawmakers were committed to the free market or not by the end of the legislative session. We also said you're more than welcome to go out and tell state employees and teachers that you don't deserve to receive some of the same benefit that Oklahoma County employees are receiving, and that a number of employees are now receiving in rural banks that are servicing some of the same state employees. As you can imagine, they all huddled together and they determined from a PR perspective it would not have been a very good position in a down budget year to advocate that the legislature should continue to overspend on state employee health insurance plans. By the time we were done, I believe the bill passed almost unanimously out of the Senate. The governor signed it. And so now in Oklahoma, 183,000 state employees and teachers are now going to have the opportunity to be incentivized in the same way that you've heard this morning from Adam and Dr. Smith earlier and Jay Kempton. We're excited about it. As you know, government can fumble the football like no other, and so we're going to stay dedicated to make sure that this happens. It's moving now. I'm talking publicly about this because I want to put the pressure on them to make sure that they follow through. The hospitals are scared, and they should be scared, because can you imagine what it's going to do to the healthcare market in Oklahoma when 183,000 people now figure out that they can save money by going to low-cost providers? And can you imagine the pressure that it's going to put on health carriers or health insurance companies when 183,000 public servants are now telling their friends at church and at school and wherever else they play in the neighborhoods that, hey, we've got this cool program where if I choose this low-cost provider and he's 1/10 of that hospital that has 5 cranes out of it right now, we don't have a copay. And so we're excited about that. We're looking forward to that. We don't receive any direct communication anymore from large hospitals, as you can imagine. And that's okay. And I'm not going to say that there's not a benefit that they provide, but you go anywhere, see where you drive around Oklahoma City, we're just like your cities. The people buying the most prime real estate and with the most construction going on, it's the hospital system.
Well, I want to thank you for everything you've done, and I'll tell you, the hospital administrator that told him that he was concerned about the direction that you all were taking wasn't as concerned as I was getting into your car.
Oh.
The way and that you have gone after these guys has been amazing. But for everybody out there, it hasn't been easy. And at the end of this, I do want to call on you guys to open your pocketbooks to what they're doing, because it has been important for the movement. Part of the founding of FMMA was Keith Smith and I and Jay saying that, the policy part of this was years down the road, that getting the government to realize they needed to get out of the way didn't need to happen, but it was a long ways away from happening. And seeing how fast the market has moved, and when somebody's willing to bulldog it through and actually get it moving has been amazing. So what you've been doing is great, but we've talked about this, can you talk about some of the background of what brought you into it and what has exposed kind of the hospitals to you?
So long story short, you've heard a lot about the Affordable Care Act, and part of my background is I was actually the director of government affairs for the Oklahoma Insurance Department right up until 2010. So I actually got to watch the guts of the Affordable Care Act. And what was interesting, I actually worked for a Democrat insurance commissioner at the time, one of the people I admire the most out of any person I've ever met. And to her credit, she had lots of experience in the healthcare industry, and she felt like the Affordable Care Act was not the answer. She knew that. She was actually in insurance, but she could see the claims, particularly as we help consumers deal with healthcare claims through health insurance companies at the insurance department. And she knew that the problem was the cost of care, not lack of coverage. In Oklahoma, you could actually find variably reasonably priced health insurance plans before the president decided to promise us that if you like your plan, you can keep your plan, and if you like your doctor, you can keep your doctor. We all know how that worked out. So I found my family and I in a transition in between the end of 2010 and 2011. A good friend of mine, Roger Hicks, he's sitting right directly in the middle in front of me. He handles the healthcare plan for OCPA. And we were in a transition period. And in Oklahoma, I remember I said it has some of the lower cost healthcare. Well, one of the awesome policies that you used to be able to find in Oklahoma was child-only coverage. And you could get that from a number of companies. Well, thanks to the administration not understanding the whole concept of risk and determining that any child policy should be guaranteed issued no matter what, because that sold really well to the public, it completely shut down the child-only market in Oklahoma. Right at the same time, I was in a job transition. So what ended up happening is that we ended up being without health insurance thanks to the Affordable Care Act, which was supposed to expand health insurance to everyone. And so I wrote a story about how it was very unique how the first black president ended up putting a black family in Oklahoma without health insurance that was trying to be responsible. So as you can imagine, I now pay really close attention to our tax return, given I make these kinds of comments now. So I'm now just a CPA out of protection of my family's own livelihood. We had a situation, you guys all have them, kids, they're wild, they're rambunctious. My daughter, she disobeyed mom and dad. We get bunk beds, my friend and I, we build them. We have just one instruction. The 3-year-old, almost 4-year-old, under no circumstances to climb on the ladder. I said that how many times that night? I can't remember it. Within 24 hours, Savannah didn't believe that Dad was serious about not climbing on the ladder, and Savannah climbed the ladder, and she fell off the ladder and broke her arm. So we were very concerned about this. We didn't have any health insurance, so we visited a children's hospital. And we went down to so first of all, what happened, and we had an experience where a daughter of ours, our firstborn daughter, had a fracture in her toe. And there was a great doctor at the time, great orthopedic doctor, Dr. Davenport and Dr. Keith Smith. They immediately know his name if I mentioned him. Used to have his own practice in Edmond, very popular. And thanks to all the help from the federal government and the cram down and the vice grip, he sold his practice out. So he treated my daughter for $85 in 2008. Fast forward to 2011, my daughter Savannah, we go into this benevolent children's hospital that's got cranes all over the place and doing all kinds of fundraisers. And I called around and I couldn't get anyone at the time, and now I know better. Now we know. Later I left Keith. I called around and I could not get anyone to give me a quote for pricing to bring our daughter in. They refused. So I called the children's hospital and I said, "Hey, got a daughter. She's kind of has trouble holding up her arm. She's not wailing and screaming, but we think it's probably broken." And I said, "So what's the estimate of the price to bring her in?" "Well, you got to bring her in because we don't really know how she is, and all children are different, and blah, 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 blah." And I'm sitting here thinking, so as I said on the phone, so is Savannah the first 3-year-old to ever break their arm in the history of known to man? "Well, sir, why don't you just bring her in? We'll get it taken care of." So I get there. I've got my credit card out. I keep asking the front desk, "Hey, what's the payment? What's the cost going to be?" And so I sign my life away, committing to pay the charge master prices of whatever they're set at. And we get to see someone. We get 20 minutes of care from the time they see them to the time I think the doctor looked at the x-rays. We actually never saw a doctor, and they put it in a cast. And I said, "Okay, so you guys did that. That's 20 minutes. You know, I was a CPA. I worked at an accounting firm. I'm used to billing by the hour, so I kind of have in my mind what the price will be." I was like, these guys are good, so maybe it's going to be $400 or whatever. So you guys should laugh at that because that was stupid. So I get the bill a week later, or 2 weeks later, and it was for $1,200 for 20 minutes for a simple wrap of an arm cast. So I lose it. And I've finished my CPA exam. I'm already really pissed off at the Obama administration because we don't have health care because of him anyway. So I call this benevolent children's hospital and I say, how is it that you guys could come up with a bill after you saw me for a broken arm, but you couldn't come up with one beforehand? And they said, well, sir, now that we know what you did. And I said, well, but there's just like one line item on this bill, and it's for the $1,200 and for treating the broken arm. And so I'm trying to understand what's going on. She said, well, sir, we don't adjust our prices, and we can't. And we have to care for the indigent, and we have to be a facility that is open to the community. And I'm just like, stop the BS. I don't have time for this. And so I said, well, I don't have health insurance. And I said, so how am I going to pay $1,200 for something that was 20 minutes? I should have gone to medical school, apparently. And they said, well, you don't have health insurance? Well, we can write that bill down to $450. That bill was a bill we meant to send to the insurance companies. And so she thought that was going to pacify me. And I said, well, what the hell? I'm supposed to feel better that if I'd had private health insurance, the bill would have been $1,200? And so I just paid the $450. And I am now in a battle with the same place. This time, it's for them just to look at a hyperextended elbow. $2,200 was the facility charge after making us wait 7 hours in the waiting room. That's why I said I agree with Adam that children's hospitals are the worst, because they'll parade children that are in need on TV, and they'll tug at the heartstrings of people. And so this led us, which was to my favorite project. It was Senate Bill 560. We were sick and tired of the public being forced into having to enter into these third-party payment systems. And some very aggressive progressive states, they're doing something that's very evil. They are backdoor essentially banning the public from private payment of health care. By deeming that a contract between a doctor and his patient is actually a guarantee of risk. So we worked with Rob Bartlett and several others to produce a bill that protects in state statute the ability of patients to privately contract with their doctor to purchase their medical care. Because as we've written before, the notion that a physician-owned facility is evil is the exact same as the notion that an auto mechanic is evil if he owns his shop, or that a grocery store owner is evil if he owns the grocery store, or if a CPA is evil because he owns his accounting practice. And so now in Oklahoma and in 11 other states, the ability for patients to contract privately with their doctor without anybody, without even a TPA, and pay $50 a month to a facility like Dr. Jeff Davenport's. It's now state law. I mentioned earlier the State Policy Network, and it is a group trade association of number of think tanks. Benjamin Rush Institute, they're here, they're in the crowd, they participate as well. I'd encourage you to reach out to me so that I can connect you with the state-based think tank that's in your state. They are looking for doctors who are challenging the status quo in healthcare. And because all of us are nonprofit organizations who take no government money, we live for the fight between the crony capitalists and the people that want to make your lives miserable. So we love to be the ones to wear the bulletproof vests and allow you to live in anonymity while we publicly highlight everything that those that are doing to block people from care are doing to prevent the good work that you're doing. So I'd love to talk with you afterwards, particularly if you're from out of the state of Oklahoma, because what I want to connect you with the most is your state-based think tanks. There's 12 other Jonathans across the nation that are sitting and waiting in a state-based think tank to be able to push the ability for you to be able to treat your patients just like you desire.
The bigger... Yeah. And as this room keeps getting bigger and grows larger, and there's more of us out there, and there's more people that are forcing this and making the market bigger and saving more money, when Jay Kempton talks about saving $14 million for his clients, and Keith talks about saving over $2 million for Oklahoma County, that money isn't smoke. That money is coming from these hospitals. And it's also, the Oklahoma County stuff is money that can stay in taxpayers' pockets. It's money that can go to increase salaries. It makes a movement, and it increases this, and it makes somebody like Jonathan's job maybe a little easier. He still has to wear a bulletproof vest because he's out in front. But we haven't talked about this much. We talked about it a little bit yesterday on certificate of need and what you were kind of thinking about. I wanted to kind of I guess wrap up, and maybe this is a longer discussion, but talking about what you see as the next steps in your role here. I mean, I look at Oklahoma, and it's out in front of everybody, and to say that what Dr. Smith was doing was going to be changing in the government, maybe the fastest and largest, would be kind of funny, but it's happening here. And so where are you looking to push next?
So we think next, just like I love the example of an auto mechanic. I tell people all the time, you can get a price from 10 different people. Actually, you can wear yourself out calling to get prices on quotes for tires. Eventually you just have to stop, and they'll all quote you, and they'll all match the price. Well, and so if they've got the expertise, there's generally no restriction on what an auto mechanic can do, or what kind of car a car dealership can sell you. Now, we want the same thing for the medical profession. The certificate of need laws, there's a lot of work that a number of state think tanks are doing. They're killing people. They're resulting in a rationing of care and driving up the cost. And it makes no sense why the Surgery Center of Oklahoma has to get permission from the state of Oklahoma and a board that is against their own interests in order to help with kidney and dialysis treatment. That's evil. So in addition to the movement of trying to protect the right for every patient in the United States of America to be able to directly pay for their care and contract with their doctor, a number of 10 of the think tanks are working on an effort to begin to repeal certificate of need laws across the United States of America, and to begin to allow doctors to be able to participate in and enjoy the same free market that others. And some of you, if there were hospital people in the room, they would have fallen out by now and had a heart attack because but pulling the veil off the cartel is found with the certificate of need laws. As I've mentioned, Oklahoma is one of the better states. There's really only about 4 things that are blocked. Now, there's significant things in Oklahoma, but it's nothing compared to states like North Carolina, where there's an extreme rationing going on where people are able to get medical care. And so we see in Oklahoma that certificate of need laws are the next place to go. We also see we are very much in favor of medical price transparency being forced on those that take Medicare and Medicaid payment. We think that if you're going to take the government's money, then we want to aid people that are using government vouchers for health care, whether through Medicaid or Medicare, to be aware of the prices that you're charging them and charging the public. The hospitals, as you can imagine, they picked their evil or poison, if you will, and decided to vehemently oppose the bill to require them to have to post the prices, the actual charges, and then the agreed to amounts of their top 100 procedures. That's the next way. We think that that's not necessary for people that are participating in the free market. If you've got a private practice and you're not taking Medicare or Medicaid payment, then you should be left alone. But once you begin to take the subsidy of government and you have become a part of the game of the reallocation of taxpayer dollars, then the public should be aware of what you're doing. As you can imagine, that one is not going over very well at all. But those are the 2 areas. If you are in a state, again, I would encourage you to either talk to me or go to the State Policy Network. If you search the State Policy Network, It has the list of think tanks and by state, and so you can click through and immediately find the state-based think tank that's there. But certificate of need laws are the next frontier for us in removing the restrictions on the innovation that can happen at your facilities.
Awesome. Well, I want you, as you have done, to use your influence and time to keep going after the hospital admins. And so I want to make a request for everybody here to open up your wallets, bring out your checkbook, write that check to the Oklahoma Council of Public Affairs, and on the memo line, write "Attention Hospital Admins," and then slip it in Jonathan's pocket a little later today and help him in this fight. It's a big deal when you take on those guys. Those are a lot of the donors to a think tank like Jonathan's, and it's a hit for him to put himself out there and take on these guys. So again, I want to thank you for everything you're doing and everything that the think tank's doing. Dr. Smith.
Jonathan, what do you anticipate the savings to be to the state of Oklahoma? Wild guess, first year. And do you have reason to believe that the other states that have self-funded state employee plans have their eyes on this and are going to be following this?
They do. There's actually a meeting of a number of think tanks that are going to take place in November to look at states that have self-insured plans. So one of the beauties of being government and being immune to the rules that everyone else abides by is that they generally can structure their self-insured plans however they want to. The numbers are real. If Oklahoma implements this fully, like Oklahoma County did, it could save Oklahoma taxpayers over $78 million a year. That's big time money, and so that you want to talk about a tax cut for taxpayers and empowering government employees that may be on lower salaries, and so that was why the hospitals fought it so hard, because if the largest self-insured plan in Oklahoma rips off the Band-Aid and takes the veil off of all of the upcharging on pricing, then no private sector company anymore can argue to their shareholders that they should continue to play the game. If the state is willing enough to do something that makes common sense on pricing, why on earth would my private business not do it? And so that's what we think is exciting about the opportunity that's there and why we continue to move it.
We're not in Ohio where you are in Oklahoma, but we're trying to get there, and the numbers are growing. But here's the problem. The State Department of Insurance in Ohio, I think, is owned by the insurance companies. And let me just give you an example. There's a concept in the physician in this room where every one of them is familiar with it. It's called prior authorization. What that means is that before you can do a test that you feel is in your patient's interest, I could give you an example, but I won't for the moment, it has to be authorized by a surrogate that the insurance company has hired. Now, Jay was talking about TPAs last night. These organizations, as I understand it, and I'm on the Medicare Advisory Committee, who represent the Medicare Advantage programs, are supposed to handle them as Medicare handles them. And yet, we're refused prior authorization on many requests for diagnostic or therapeutic treatments for Medicare patients who are in the Medicare Advantage program. Is this the type of issue we take to the council that you're talking about?
I think so. One of the things that, real quick, is that, and I appreciate that concern, but the reason that we moved to do what we did in Oklahoma is that you're going to have an employer with a large enough pool that sends enough of a shockwave to the rest of the system for them to change their incentives. And so if you want to end the abuses on pre-authorization, then the first place you need to start is with the people that have the best ability to protect themselves from the environment that they've created, and that's state government. Many of the states, they have self-insured plans. And while they're okay with bad provisions for other people, they generally are not okay with living under bad provisions for themselves. And that's why we've moved and worked here to give the self-insured plan in Oklahoma this capability, because it's going to be in their best interest, given the significant state employee and teacher presence in those plans, to actually do what's best for patients. So I would encourage you, and I know the guy that does healthcare at the think tank in Ohio, I would encourage you to reach out to them. They're looking at getting their self-insured plan to shift and do exactly what Oklahoma and Oklahoma County's doing. And that's what will cause the shift or the change in the way the market's created.
And I think the guy you're talking about is Ray Hederman.
Yes,
right?
That's exactly right.
Ray Hederman isn't exactly Jonathan Small, but he is the second best thing. He was a guy that was one of the better healthcare thinkers in DC. Realized one of the same things that I did is that we needed to get out and do something different. He's doing some really good research on hospital monopolization right now as well. So go talk to Ray, and he can help point you in the right direction. Dr. Drew?
Three things. First, I noticed that we don't have a wrap-up session, and I want to take this moment to thank the organizers for doing this. You guys have really...
Appreciate that. Thank you.
Not only have done a good job, but opened my eyes, even though I've been doing this, as I like to say, for 30 years. So thank you. Number two, Mr. Kelly, who's just there, you're a visionary, and I think you're right. I'm an internist, so I do take care of folks who have to go to the hospital, but not often, because as I like to say, I only go to the hospital in the middle of the night because some lady gets up to pee and breaks her hip, which is a preventable disease when you think about it, or when my pneumonia vaccine doesn't take. But I do want to just caution you that and not that I'm in love with hospitals, but we have to find a way to empty the hospitals, as you say. But there's always going to be some need for that. And the other thing I want to throw at you before I come to you, Jonathan, is electronic-based medical records are not a good thing. I have a paper record, and I'm very, very, very proud of that because it costs me a lot less, and I don't have to pay an IT monkey to come and tell me, sorry, we can't fix that. So the point is, my financial records are actually a ledger card. And today, listening to you and to Maria, I'm thinking, since I'm a cash-only practice, is that I actually shouldn't have a financial policy for the office, because I do not want to be bound by contract language that may come back and haunt me, and I think that goes to what Adam was saying. So, Jonathan, my question here, and my third point is, what are the hospitals doing in response to this?
So I had this conversation with Keith, and if you know Keith and if you know Jay, they hate the government process. But here's been the problem, a rallying cry. People in this room that support limited government, free markets, and individual initiative, we have done this silly, stupid thing, which is that we have thought if we extract ourselves from the exchange of government, that they'll just leave us alone and let us do our thing, and that's not it. One of the things we're doing is we're working the game like they are. Lobbyists, they'll take anyone's check, and they'll take our checks just like they'll take theirs. And so we are beginning to play the policy advancement game to the very same level of success that they are. We're using messaging campaigns. We are doing things like doing TV interviews. I get great joy out of the fact that we were told to our faces, you don't know what you're talking about. Hospitals will never post their prices online. That's arcane, that's archaic. Steve and Keith, they're just nuts, and nobody's going to do that. But guess what? I know that the marketing PR for one of the largest hospitals told them, you can't keep getting on TV telling people that they can't find out the price of something online, because they can do it for everything else. So guess what? The largest hospital system in Oklahoma finally put prices online. Now they're BS prices, but they admitted they could no longer fade the heat of not sharing prices with the public. The big thing that the hospitals are doing, the number one thing that they're doing across the country, is they're realizing that if they just fight the game in the urban centers, that they're going to lose. Because, when people can get a car through Uber and do all of those things, the public won't put up for it. What they're doing, though, is they're buying rural hospitals. And then they're taking on and so then they buy a rural hospital, they make that rural hospital take on their charging and pricing structure. Then magically they report all this BS uncompensated care. And then they go to the legislature and they say, well, but, Oklahoma City and Tulsa's hospitals, they have tons of profits. But we use that profits to offset the feeder systems. The community development systems that we're funding in local rural areas. So across the country, the number one thing that they're doing is they're gobbling up as many rural hospitals as they can as possible. And that's why the Medicaid expansion won't help rural hospitals. Because think about it, you're going to have a higher percentage of people coming from urban areas that are going to be on Medicaid. So the few more able-bodied patients that you get at your rural hospital are not going to save it. It is going to create a feeder system, though, for the larger urban centers. And so that's why I think that that's why we're aggressively moving in a number of the state think tanks to advance public policy that frees up doctors and awakens them. That's why what the Benjamin Rush Institute is absolutely awesome. I had the privilege of just totally rocking the world of the Medicaid agency and the former Medicaid director at a meeting with over 100 Tulsa's medical professionals. I am telling millennials that hospitals want them to be their slave and their employee. Did you get $200,000 in debt to be somebody else's slave and employee and to be told what to do? And most of them are looking at me and saying, yeah, you're right, I didn't do that. So do you want a government that can't balance its books to be what you have to rely on to get reimbursement? So I think that that's the number one thing that we've got to watch for and highlight. That I had this discussion with someone this week. They are buying rural hospitals purely so that they can offset the losses against the massive profits that they're having in urban centers. And just like what Jay mentioned, do you think that they're going to allow somebody to use that equipment at that facility if that rural hospital sells off I-40? No. They're going to give them a referral and they're going to tell them to go to Oklahoma City or Tulsa. And so that's the story that we have to tell a lot of the rural centers, is that if they're coming for them next.
Over here, and then we'll come over there.
Hi, yes, I just wanted to respond to the gentleman's point about pre-authorization. One of the things as a TPA that we are required to do by the employer is determine medical necessity, which is also called pre-authorization. And so it's a very important aspect of what we do. All of our employers have stop loss, and the stop loss companies require that they have that as part of their policy. But it's really something that, if I can explain it right and articulate it properly, it can be your friend. We're the TPA that handles the county of Oklahoma. And so when we perfect medical necessity and get authorization, if we find that they're authorized to go to one of the high-cost facilities, we're redirecting them post pre-authorization to Dr. Smith and other like-minded providers.
Thank you.
An example of what that reauthorization did is it saved an Oklahoma County patient who needed a robotic hysterectomy from having to pay $90,000 to just $10,000. That's an example of where a prior reauthorization with someone who's your friend, a TPA that gets it, that's working for the seller and the buyer, not an intermediary, can make a huge difference. Yes?
Hey, my name's Raj Barol. I appreciate everything you guys have talked about today. I am a cardiac electrophysiologist in Dallas. I run a 70-person cardiology group. We're the largest independent cardiology practice left in the United States. About 2 years ago, I took over the group. In 2013, we were 75 cardiologists when I took over. And shortly after I took over, about 20 to 25 of them left our group to join the hospital systems. We were basically at war with the hospitals. And we lost a lot of experienced cardiologists, a lot of good cardiologists, and we've spent the last 2 years repopulating Dallas-Fort Worth with independent-minded cardiologists, giving them much the same message that you've been giving the young doctors. So now we're back up to about 70 people. And our competition is the hospital-owned cardiologist groups, and the hospitals pay significantly more for their services than they do for us. Using a free market medical association mantra, our group is going to move forward in the years to come to try to figure out a way to have a sustainable model. I mean, I'm fortunate that the guys that we've replaced the older guys with are very aggressive and doing a great job. We've actually been able to replace the work that they did effectively. The title of your talk, at least it says in there, talks about the legal ramifications of hospitals taking over practices and running physician practices and what's going on in the legislature. I was wondering if you could comment about anything coming up in the future that the doctors in this audience can learn from as the independent practitioners try to fight the hospital systems, tooth and nail to try to protect our practice.
Well, so one of the great things that the think tank is doing, so you need to talk to the Texas Public Policy Foundation. They're our sister organization. John Davidson is their director of healthcare policy studies. So one of the things that the think tanks are beginning to do in mass is begin to write stories about the massive consolidation that's going on in healthcare. To expose to the public what's going on, and to get the grassroots excited, and I don't mean excited in a joyous way, but excited in an angry way and stirred to action about what's going on, about just what you talked about, and the amounts of dollars that are being spent to acquire these practices. Part of what's going on is these hospitals are going to, I know what happened to that orthopedic doctor. I've been told since what happened to him. He got offered a ridiculous amount of money. And so when he talks to the extended family about what their estate planning is going to look like, when you get offered 7 figures, and then you can go to the state hospital or the nonprofit hospital and make nearly $500,000 a year for the next 10 years, that's very difficult to overcome. And the only thing that's going to stop that is by getting the public involved and seeing. So one of the unique things is, although liberal reporters have been reluctant to talk about the bad components of the Affordable Care Act, one of the things they have been willing to talk about is what's going on with the cost of care. And so that's what I would recommend. What the problem is for us, that some of what would fix this is not based in the free market. So for example, the FCC and others, they're the ones that are supposed to be looking at the consolidation that's going on. And of course, they're conflicted because these guys are giving them all money. But so I really think educating the public about what's happening, highlighting what's happening. I started telling the story about the fact that we were able to go to this guy in his own facility in 2008 for $85. But then we're getting these stupid facility charges now in 2011 for the same exact level of care, and showing the public that it's the same facility, same doctor, but because the name on it is now the big hospital system, there's this now franchising tag, which provides no value. And so that's what I think is the most important thing, is either, if you're, depending on who you are and where you are and what your business interests are, if you think you're in a position where you can't stand up and say some of the things that that are going on, I encourage you to give what that's going on to the state-based think tanks. And they'll write about it, because that's what they exist to do, is to highlight to the public what's going on.
All right, we have another question.
I'm John Flo. I'm a second-year medical student here with the Benjamin Rush Institute. So thank you for speaking. I agree that the more doctors we have, the better it is for the consumer patient. And I'm just wondering kind of what can be done on a state policy level to get around the graduate medical education funding issue that seems to be the bottleneck of the supply side of medicine?
We've been thinking about how to deal with that. That's a really tough question. When I was in that room, as 100 students, there was probably over $50 million in debt represented in that room cumulatively. And this is another story. It's no coincidence that the two things that are the most ridiculously priced in the United States of America are the two things where government has been most involved in wreaking havoc, and that's healthcare and higher education. Higher education is almost as evil as what's going on in healthcare. It depends on what day, which one I think is most evil. But I think that it's going to take medical professionals stopping writing big checks to the alumni organizations and being pacified with your name being put on halls. And I know that's difficult to say because, you played football or you watched them play football or you guys were in, fraternities or whatever. But there is all kinds of nonprofit money going after bad in higher ed and medical care. And that's going to be the first thing that will stop that. The next thing that needs to happen is some facility or some institution, I don't know who it's going to be, is going to say, we're going to figure out how we're going to be able to have the most low-cost medical degree program, and we're going to advertise it. Rick Perry did it in higher education on some other degree programs in Texas. But that's what we're really going to have to see to really able to open the door. I don't want people that don't work hard in medical school, but what I also don't want is an incentive right now that weights doctors and students like yourself to being employed because you've got $300,000 worth of debt. And so the first thing you're thinking about is, I just need a check to pay off this debt. And so that's what we're going to have to see. Some university president, who knows, maybe it could be Mitch Daniels. Mitch Daniels is really shaking up the higher ed world in Indiana. But that's what we're going to have to see is a medical university is going to have to look with self-reflection and get its alumni to say, okay, we're going to stop donating to expanding the footprint of our campus across the city and instead dedicate that to scholarships and see how low we can make our medical school for the next generation of students. And I know that's radical and that just put a lot of higher ed and admin staff out of work, but we enjoy doing that. So.
Thank you again.